I'm, I guess, tagging you because, and I'll let you introduce yourself in a second, but just to get right to it, I identify you as the leading expertise in just having a conversation around harm reduction and what that means. So if I guess you could go ahead when you're ready, and go off more or less on what is harm reduction and why is it in the context that we're in right now with historical trauma and unresolved grief and substance use disorder and COVID, nonetheless, why is harm reduction a model that should be the priority model? Or I guess, why should it be really considered as opposed to adversarial models, if that makes sense? But go ahead, introduce yourself and then take it away.
Sure. Well, my name is Dave Lucas, and I'm a social worker with a background in addiction and mental health treatment. I've worked primarily with folks involved in the criminal justice system in Canada and the U.S. And I've been a long time advocate for the use of harm reduction principles and philosophy in both in the community level and also in clinical and legal settings. And I think that has to do with the fact that I think what we've seen in the research is that what works in terms of promoting healthy living and people making change at a pace that tends to work in the long term and promote health in a way that is client-centered and more likely to kind of withstand the pressures of other actors like police and other social forces. I guess the reason why harm reduction has a particular kind of relevance right now during COVID is because everybody is kind of doing harm reduction to an extent. Quarantine, shelter in place, wearing masks, washing hands, physical distancing, and also providing additional social supports and resource supports for people who might be going without at a time like this. All of these things are kind of examples of harm reduction, which are basically, harm reduction is a huge kind of school of thought, and it has different aspects to it. You could trace it back to the origins of, fighting for medications during the AIDS crisis, and then you can also consider it access to medications in the current opioid crisis, and as well as things like naloxone. But it's also a fight for racial justice. It's an anti-colonial movement. It's an anti-racist movement that recognizes that a lot of folks have addiction and mental health issues as a result of historical traumas and legacies of racial violence. And so it's kind of an all-encompassing approach to things that recognizes that we can't change things overnight. The social forces that cause a lot of the harms that people who use drugs face, it doesn't always have to do with the drugs they're using. It doesn't always have to do with the fact that they have a mental health condition. A lot of it has to do with what happens to them once society recognizes that place that they have in those challenges that they face, and the fact that they're often reharmed by systems that are charged with taking care of them. So harm reduction is, as an approach and a philosophy and kind of like a movement, is partially trying to be a buffer towards the systems that kind of reinforce and reproduce some of those harms that originally kind of caused or are underlying a lot of the addiction and mental health issues that people face. During COVID, it's particularly important to think about harm reduction principles as opposed to, say, like forced abstinence, because we have to be realistic here and we want everybody to be safe and taken care of. And when we do things like restrict people's access to substances that they've been using, say, on a daily basis, whether that's opiates, opioids, or stimulants or alcohol, there could be really, really dangerous outcomes. So, for example, if somebody is a daily drinker, a heavy drinker, and they're suddenly cut off from alcohol, they could actually die from withdrawal. Folks don't usually die from withdrawal of opioids, but you can go through extreme pain and distress to the point of where you could potentially be so dehydrated that you could die. It's rare, but it's possible. But it's something we certainly want to avoid. It messes with people's tolerance, and then when they do eventually get access to opioids again, their tolerance is all out of whack, and there's a really high chance of overdose risk. So there's all kinds of precautions that we want to take when thinking about people with addiction issues during COVID, because every risk that they face kind of normally, they're facing in an intensified way. So are they facing maybe potential eviction? Or do they have less access to food? Are they not able to pay for, they're not able to do their gig economy type jobs or their side hustles to make ends meet? So suddenly that they're without kind of those basic necessities. So they're facing a lot of social problems. In addition to that, they're going through all the physical and or physiological distress that comes with being in withdrawal or not being able to access their substances. And then it gets just really dangerous. So, there's two approaches you can take. You can say, well, that's them's the breaks, and that's what they get for living a life on the margins like that. Or you can say, what can we do to support this population and keep them alive? Because ultimately, if we're trying to observe COVID directives, it's because we're trying to keep people alive, whether they use drugs or not, whether they have mental health issues or not. We want everybody to survive this thing together. So harm reduction in its most purest form is really about care and compassion and mutual support and non-judgment and meeting people where they are. And that means that if somebody is using substances and we, during COVID, decide that, wait a second, we're not going to allow these people to have access to things, we have to be prepared for the fact that that's going to have extremely, it's going to have really dangerous outcomes, most likely. So we need to do some planning around making sure people have access to addiction and mental health care services, harm reduction services, so that they can do some planning and stay safe.
Thank you for that. Do you mind sharing in the next minute or so your experience working in Canada with First Nations and, well, I say First Nations, but if you happen to have clients who were First Nations, I think this really is, for me, mind-blowing, just the level of, I don't even know if the word is acceptance, but just awareness and implementation of harm reduction for substance users. And I know your area is, or the area that you can speak to is opioids, but in my community it's methamphetamines and alcoholism as the leading top two. Sure. I could be wrong, but if you could speak to your experience, that'd be great.
Yeah, I mean, I'm certainly not an expert in the in the best in developing or creating or delivering culturally appropriate responses for Indigenous communities, but I certainly have worked with a lot of Indigenous people in my time, especially in Canada. I'm from Winnipeg, Manitoba, so I've worked in the much maligned, for good reason, child welfare system here as a youngster, just kind of entering the field, and then I started working in the addiction and mental health field in Toronto, where I worked with a lot of street-involved people, many of whom were Black or Brown or Indigenous, and I've seen kind of all substances in Winnipeg, and there's a lot of alcoholism and crack use and meth use and opioids and other kinds of painkillers. Certainly, in Toronto, it's very similar. You see pretty much all of the substances. The folks that I worked with, the Indigenous folks I mostly worked with, were using crack cocaine and alcohol for the most part. That was very common. And my experience was that what worked, or at least was a bit more effective in terms of like engaging with that population and making sure that they stuck around and came back to get more support was, number one, seeing other people that looked like them in the services that they were accessing. So representation was important. And then also just people who recognized kind of the historical legacies that were underlying a lot of the things that they faced and why they were, so secluded and often isolated in big cities like Toronto. In Winnipeg, our colonial legacy, I think, is a little bit more upfront. We have a large urban Indigenous population, so people are a little bit more aware of kind of that kind of aspect of our history. Whereas in Toronto, it's so multicultural that sometimes that story gets a little bit sidelined, so you don't see it as much. But I did work at a hospital that had an Aboriginal program. We had a space where people could do smudges and sweats, and a lot of our Indigenous clients did find that to be particularly helpful. But my big takeaway was basically cultural practices, as much as it kind of is thrown around like, almost as a proxy for, if you just throw people of the same culture in the same room, it'll fix itself. And I don't think that's true. But in the case of working with Indigenous populations where they had Indigenous leaders leading those therapeutic processes, it was hugely significant for them. And especially when they were able to kind of merge some of the more kind of Eurocentric approaches like cognitive behavioral therapy and motivational interviewing, and we kind of merged those with practices that connected people to the land and other kind of practices. So that I found that to be hugely significant in terms of retention and kind of more long-term success. But ultimately, what was the biggest challenge for this community was, what happened when treatment ended. They still go back into a society that does not, that is still very white dominated, at least in the two cities I've lived in. So a big focus for us was to try to make sure aftercare and linking them with other kind of culturally appropriate services for when treatment was over was really, really important, because it's very easy to, as they say, it's easy to forget a language when you don't use it, and I think that goes for a lot of other types of ways of knowing and moving through the world. So that was something that I learned. But one thing I learned also from working with that population was how severe alcohol withdrawal can be, and that was something that I wasn't aware of because I was more familiar with working with illegal drugs. So when I had clients who were going through alcohol withdrawal and just how painful and how scary and dangerous it was, and so I found that it was really helpful when they were able to incorporate harm reduction practices like managed withdrawal, or just setting goals around reduction of use, and setting limits and having people to kind of be accountable with, so that if alcohol was kind of inevitable, it wasn't going to always be an excess, and that there were safety plans. People weren't necessarily going home alone in case they had maybe used substances along with the alcohol, which makes the overdose risk very high. So this is kind of where the harm reduction comes back in. Not everybody's ready to quit drinking, but they know that they have to do something or else they're going to die from it. So this is where harm reduction is so useful, because it kind of says to the person, okay, you decide what works for you, what's realistic, what will be helpful, and what feels safe, and I'll help you try to strategize around that. So let's set some drinking goals for the week. Tell me what you're usually drinking, when you usually get in trouble in terms of, hangovers and feeling sick or spending money or getting into fights or whatever the kind of goals for this week, and we'll come back and reflect on how those went and strategize about what would help meeting those. And it's, it's a really straightforward, non-judgmental conversation. In fact, I think once we untrain ourselves from imposing our own kind of goals on people, it actually becomes the easier conversation to have. It feels really natural, because it almost just feels like you're talking, it's one human to another who really just cares about that person getting through the day, and and not feeling judged. If you walk into an office and somebody looks down their nose at you and tells you that you need to stop or they're not going to help you, well, that's not going to obviously do anything. That's going to push that person away. So We want to do the things
Yeah.
that make people feel accepted and make them feel like that if they fail and they don't meet their own kind of goal, that they can come back and there won't be judgment and they can start again, you know. So but the key is the key is how do you get them back, and that comes from you know, fundamental non-judgment and
planning into the look, you're gonna stumble. We all stumble when we're kids, when we're babies, we stumble. We get it. It's part of learning how to walk. But I guess what I'm trying to say is, you know, that like when
recurrence of use or relapse.
Yes. Relapse.
Yeah,
I hate that word,
yeah.
but yes.
I do too. Yeah, I prefer recurrence of use or return to use, but yeah, it's inevitable, and you know, a big part of it is looking at somebody's return to use and not condemning it to good or bad, you know, because even if they don't drink, that's not necessarily good, because you know, maybe something still was really challenging for them, you know. So the point is, like, using is not inherently good or bad. It's basically what is that person's relationship to that substance, and what is the impact it's having on their life. And we can't, if we get stuck in these black and white binary kind of understandings of use, we can't plan. We don't learn anything from it, right? If somebody says, you know, I messed up, I drank over the weekend, I'm so stupid, and I want to stop, but I'm too weak to do it. Well, you don't learn anything from that, right? You don't. That's a conversation blocker. And if somebody, for example, gets through the weekend and doesn't drink, and you say, you know what, you're awesome, you're so strong, I knew you could do it, that's also a conversation blocker. You still don't learn anything, right? So we need to just kind of always get in the habit of like figuring out what worked, what didn't, what could be done differently. How do you feel about the goal that we set? Was it too much pressure? Was it, you know, do you want to kind of push yourself a bit more this week? You know, it's about kind of those little gradations as opposed to these kind of big overwhelming steps that put so much pressure on people who already, you know, are feeling it. You know, it's very rare to meet people with addiction issues who don't already beat themselves up on the regular, and don't be fooled by the, you know, the facade or the machismo of like, you know, the kind of the tough guy persona. Those people beat themselves up, and it takes one or two conversations between before they're, you know, tearing themselves down for all their mistakes. So we don't need to pile on to that, you know.
Right. Well, on that note, what is your response if say a country, a sovereign country, I'm not talking about North Korea, but what would you say to some country that, you know, took it upon itself to impose fees and fines on said recovering person, healing person who's in healing, thousands of dollars beyond their yearly annual income? Like, what would you say to that in terms of harm reduction and everything you've been mentioning? I guess is in the stark contrast. What is your response?
Yeah, I mean, I think realistically, you know, sometimes really strict punitive sanctions hanging over our heads works, right? Like if somebody said, hey, if you eat that ice cream cone, I'm going to punch you in the face. And you know what? I want that ice cream cone, but I'm probably not going to eat it. So in the short term, it would be effective. But ultimately, is when that guy's not there to punch me in the face, and then you know, that stick is out of my view, is that going to really change my desire for that ice cream? It's not. And so that's, you know, there's all kinds of external motivators that we can use to try to change people's behavior, but they only work when they're matched with internal motivators and the supports that reduce the desire and demand for substances. And if you know, the thing is, somebody who's addicted to alcohol or opioids, I mean, look at the laws in the U.S. There's extremely punitive. Has that done anything? It's never stopped anybody. All it's ever done is made it harder and harder for people to get help. And it's made it hard. And it means that people use alone, they use in secret, they use in the shadows, and that's why they overdose. That's why they die alone. And that's why they don't call the police when they could to get help, or an ambulance, you know, because they're scared of the fines. They're scared of getting arrested. And so what you're doing is you're basically saying, we're not interested in supporting you. We're just going to tell you what we want you to do, and it's up to you to figure out how to do that. Now, that's fine if it worked, but it doesn't. So it's actually really lazy and short-sighted, to be honest. And I know that sounds kind of critical, but all we have is evidence that those types of tactics don't work. There's no country that has come down hard on drug users and it's worked to reduce the harms associated with drug use. Only the countries Only the countries that have shifted their support towards health systems, things like housing, diversion programs, getting people kind of like vocational support. Those are the only countries that have ever had any success reducing those harms, like disease transmission, overdose, injection use, homelessness. So, you can, it all comes down to what playbook do you want to use. Do you want just the appearance of making it look like you care, or do you want to actually have an effective system that actually responds to the needs of your people? Because that's the Eurocentric, very kind of punishment-oriented approach that is basically if we look through history, why has that existed? It's only ever existed to control black and brown bodies, right? And Asian bodies in Canada with the opium dens and trying to keep Chinese immigrants away from white women. So if we want evidence that that's not the system to impose, we have to ask ourselves, what are we trying to do? Are we trying to control a particular segment because we don't like them, or do we actually want to fix the underlying problems? But harsh punishment in this drug policy space is just an extension of that legacy, and it's not going to work. So it's going to scare a few people, but it's not going to stop them from using. That's the sad thing. They'll just do it in secret, and then they living in the shadows even more.
Right. Not to mention if you have, like you mentioned earlier, mental health, depression, anxiety, suicidal ideation, that's running rampant in my community. And so I guess to spin it into what my elder says, planting seeds rather than, looking at the devastation of colonization's mess, but really to plant seeds is to really recognize or take the time for yourself to, tend to your own garden, whatever that may be, whatever healing that may be. And it might be with a six-pack, without a six-pack. The point is that you are staying connected and that you are, that you're wanted and that you have a responsibility. And that's it's a very strong Apache ethic. And I think that that's powerful across a lot of Native communities. I can't speak for all of them, but I think that this ethic around original instructions and everyone having responsibility and everyone coming and part of your responsibility is to heal. That is part of your responsibility is to heal, because we need you. We need everyone on the front lines with COVID. This is not the first time. There's going to be more COVID. We have to prepare now. We have to look out for everyone. So anyway, last 30-second takeaway thoughts, or just what do you want people to know about, what would you like people to know?
Well, I think you really framed it beautifully by saying that, people who feel cared for will care for themselves as well, and they will see that as a responsibility. And if you give them responsibility within, some kind of system of care, they will take that up, and they'll probably be one of your best workers because they understand both sides, right? They value it in themselves, and they can see the pain that the other person is dealing with. So, we're wasting a huge resource by shunting these folks to the side. I think I like the framing of responsibility there, not so much pull yourself up by the bootstraps, but give people things to do that mean something. And when people feel useful and helpful and supportive of others, they have a reason to take care of themselves, because sometimes it's easier to care for others before you care for yourself, but slowly that shifts. And you see that the better, the stronger you are yourself, the more you can help others. And that kind of that's the echo chamber that you really want. And I think that comes from top down. That's often, you see that in leadership. You see leadership that listens to everybody and cares for everybody. And you try to, and we're seeing this in the U.S., right? This approach, you don't see care and compassion at the top, and that's why you see it just kind of everywhere you look. So I think that would be the final takeaway is however you respond to the situation in your community around COVID, it's got to be collective, and it's got to be rooted in compassion and non-judgment, or you're just going to lose people and you're going to undermine all of the work that you're doing.
Right. Absolutely well said. And that's a missed opportunity we cannot afford. So thank you so much for that. I really appreciate your time.
Yeah, of course. No problem. Anytime, Noel.
Yeah. We'll talk soon. Appreciate you.
All right.
All right, later.